Good morning. Allergic bronchopulmonary aspergillosis, a comprehensive review. Today, I will be talking about allergic bronchopulmonary aspergillosis, ABPA. It is a hypersensitive disorder caused by Aspergillus fumigatus. It is an underdiagnosed condition commonly affecting patients with asthma and cystic fibrosis, leading to recurrent infection and progressive damage. So let's talk about the pathophysiology of allergic bronchopulmonary aspergillosis, that is ABPA. Also its clinical presentation and diagnostic criteria, treatment approach and challenges, and the importance of early recognition to prevent lung fibrosis. So let's first start with the pathophysiology. ABPA, allergic bronchopulmonary aspergillosis, is caused by exaggerated immune response to Aspergillus fumigatus, a common environmental fungus. Inhaled fungal spore colonize the airway, leading to type 1 hypersensitivity reaction. It is IgE mediated allergic response causing airway inflammation and bronchoconstriction. There is also type 3 and type 4 hypersensitivity reaction, which causes formation of immune complexes and T cell mediated damage, leading to lung disruption and fibrosis. There is a mucus plugging and central bronchiectasis, which result in chronic inflammation, result in bronchial dilatation and thick mucus production, which worsening the respiratory symptom. So, what are the risk factors for ABPA? First is asthma. Asthma is supposed to be 1-2% in asthmatic develop ABPA. In cystic fibrosis, it has been estimated 10% prevalence. In immunocompromised condition, though rare. So let's talk about the clinical presentation. Patient with ABPA often present with first is a acute symptom. There is a recurrent episode of wheezing, cough, breathlessness, and also chest tightness. Thick brownish sputum with mucus plus plugs. It also causes fever, malaise, and weight loss. In chronic and progressive symptom, there is a central bronchiectasis which causes persistent cough, hemoptysis. Due to pulmonary fibrosis, there is a progressive respiratory failure, asthma worsening, and there is a poor response to conventional therapy like bronchodilator. So why is ABPA, that is allergic bronchopulmonary aspergillosis, misdiagnosed? Many cases are mistaken for poorly controlled asthma or recurrent pneumonia, delaying treatment and leading to lung damage. Now, in diagnosis, early and accurate diagnosis of ABPA, that is allergic bronchopulmonary aspergillosis, is crucial to prevent irreversible lung fibrosis. ISHAM criteria for ABPA: in asthma, at least 6 of the following should be present. One is the asthma or cystic fibrosis. Second is the elevated IgE level, that is more than 1000 international unit per liter. Aspergillosis skin test positivity or specific IgE. Peripheral eosinophilia, which should be more than 500 cell. Serum precipitin or IgE against aspergillus. Radiological finding: central bronchiectasis, mucus plugging, transient pulmonary infiltrate. Radiology: HRCT, central bronchiectasis, mucus plugging, finger in a glow sign, and in chest X-ray there is a transient infiltrate or consolidation. Laboratory finding: serum IgE more than 1000 units, increased eosinophilia more than 500 cell positive, aspergillosis species specific IgE upon IgG. So now let's talk about the treatment, and the goal of the treatment is to reduce inflammation and prevent exuberation and fibrosis. So control fungal colonization. The first line of treatment is corticosteroid, which is supposed to be mainstay of the treatment. Oral prednisolone 0.5 mg per kg per day for 2 weeks, then taper over 3 to 6 months. It reduces inflammation and lung damage. Second is a antifungal therapy, azoles, itraconazole, voriconazole for 3 to 6 months, which reduce fungal load and decrease antigen stimulation. Biology, the new treatment for steroid resistant cases: omalizumab, that is anti-IgE monoclonal antibody, and dupilumab, IL-4 and IL-13 inhibitor. In supportive care, inhaled corticosteroids and bronchodilator. For asthma care, chest physiotherapy for mucus clearance. You have to regularly monitor IgE level and lung function tests, help assess disease control. So, in conclusion, ABPA, that is allergic bronchopulmonary aspergillosis, is a serious but treatable condition. Early diagnosis and proper treatment are crucial to prevent progressive lung fibrosis. General practitioner, pulmonologist, and allergist must be aware of ABPA in patients with asthma and cystic fibrosis, especially those with recurrent exuberation or central bronchiectasis. So, take home message is always suspect ABPA, allergic bronchopulmonary aspergillosis in asthmatic patient with poor control and recurrent infection. Elevated IgE and eosinophilia should prompt further evaluation. Corticosteroid and antifungals remains the cornerstone of therapy. Newer biologic, that's a newer drug, offer hope for steroid dependent cases. Thank you.